Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training. Today we're continuing our pharmacology lectures. We're talking about immunosuppressants today, a very commonly used medication, though not every doctor is going to use immunosuppressants. Though you need to be very aware of their mechanisms of action, know how they affect the body, because they're going to be really high yield on a lot of testing. So let's get started. So the immune system is a very complicated mechanism, and it acts to protect the body against infections and foreign entities. Now, it's an impressive show of force against all potential invaders, but maybe what's most impressive about it is that our immune system has the ability to direct its arsenal only on foreign invaders. It's able to recognize the self and then leave it alone. Where the system becomes problematic is in the case of organ transplantation. Now, this is no longer a rare occurrence. Now, you'll hear about this all the time. We transplant hearts, kidneys, livers, bone marrow. We're transplanting things left and right all of the time. Now, in this situation, we are purposefully introducing a foreign organ into the body. So we're taking something that shouldn't be in the body necessarily and putting it in there. And we want to prevent an immune response in order to keep the body from rejecting the organ. So we talk about organ rejection in these situations, and we want to prevent that. Now, fortunately, we have drugs that can help prevent the rejection process. But unfortunately, many of our drugs are non-selective, and there's a risk of compromising the entire immune system and putting the patient at an increased risk of infections. So we want to keep the organ around, but we don't want to completely wipe out all of the immune processes that keep us safe. So our lecture today will cover the drugs used to help suppress our immune system for the purpose of preventing organ transplant rejection. Now, there are other medications that we can use that suppress the immune system that we're not going to talk about today. Now, these medications will be covered in other lectures like our anti-inflammatory lecture and our anti-cancer lecture. So some of these medications, there are some cross reactivity, some similarities between them, but today I really want to focus towards the medications used in organ transplantation. And even these medications can sometimes be used for other problems, but we'll try to focus it a little bit more today. Now, one approach for our medications, especially the ones we're using today, is that because they work by different mechanisms, we try to combine them for an overall immunosuppressive response in these situations of organ transplantation. So instead of using one drug at a very high dose to achieve the effect of immune suppression, we try to use 3 medications at lower doses to achieve the same result. Now, why do we do this? Well, one is because we use different mechanisms and we can kind of cut off different avenues of rejection. But 2, we want to decrease the overall toxicities of these medications. And that's the problem with immunosuppressants, is that if you use high enough dosages, you're going to run into more toxicities. So lower doses, multiple meds, we get a better overall outcome and decreased toxicities. So let's move on. First, I want to talk a little bit about an overview of the immune activation. So our immune system is very, very complex. We have several layers of protection to keep us safe, and we need all of them in order to stay healthy. First, we have a mechanical barrier. Now, our skin is the first line of defense against any infection or any foreign invasion. However, as organisms, we can't completely be sealed off against the world. Right now, my mouth is flapping up and down, and it is potentially an opening for the world in order for foreign invasion to come in. So we have these openings like the respiratory tract. We have a GI tract, gastrointestinal tract. We have a urinary tract. So we have these open areas. We have mucous membranes everywhere where organisms can get in. Now, that's not the only way organisms can get in, but it's a pretty easy avenue for them to infect us. Now, fortunately, if we have a failure of our mechanical barrier, we have other layers of defense, including humoral and chemical barriers. So inflammation is one of the first responses of the immune system to infection. So inflammation is produced by eicosanoids and cytokines, which are released by injured or infected cells. Prostaglandins can produce fever and dilation of blood vessels. Leukotrienes can attract certain white blood cells. Interleukins are responsible for communicating between white blood cells. Chemokines promote chemotaxis, and interferons have antiviral effects. So we have lots of small microorganism fighters out there. We have lots of proteins, lots of molecules out there that their sole purpose is to move the right type of antibacterial, antiviral, antifungal mechanism into the right area. So it's moving everything in the right direction in order to fight off any infection that comes in. B lymphocytes are responsible for producing antibodies to antigens to again lead to killing of infections or foreign invasions. We have a complement system, if you've heard of that before, where complement binds to antibodies that have attached to microbes already, and this will facilitate a more efficient killing. Phagocytes like macrophages, neutrophils, dendritic cells, these all engulf pathogens. And then lymphocytes are responsible for eliminating very specific targets. So you'll see this is a huge topic. We've got so many different mechanisms to fight off infection. We can't go over each and every one of them in tremendous detail because that's why we have immunology as a whole course. So that's why we just can't spend that much time talking about each one. But since we're talking about pharmacology today, I do want to focus our attention on how the drugs affect our immune system in very specific ways. Now, most of these drugs are going to affect lymphocyte function or inhibit the function of many of the immune proteins. So our first ones that we're going to talk about are the cytokine inhibitors. Now, the cytokines are a large group of small cell signaling proteins, and they're involved in intercellular communication. So in regards to this lecture, we'll concentrate on their involvement in the immune system because there's a ton of different cytokines and we can't talk about all of them. So cytokines include interleukins, tumor necrosis factors, transforming growth factors, and colony stimulating factors. The cytokines are soluble molecules and they bind to cell surface receptors on a variety of cells. The one we're going to talk about a lot today is interleukin 2, sometimes referred to as IL-2. And it's of special importance in our talk about our immune system today. So interleukin 2 stimulates the proliferation of antigen-primed helper T cells. Now, these cells then produce more interleukin 2, or IFN, or interferon gamma, and TNF, or tumor necrosis factor beta. These cytokines overall will activate natural killer cells, macrophages, cytotoxic T lymphocytes. So there's this upregulation of the immune system here. So overall, the IL-2 is very important. It starts the process of getting one cell stimulated, which then stimulates more cells, which stimulates more cells, and then you get this overall activation. Therefore, one strategy to inhibit the immune response is to inhibit the actions of interleukin 2. So the first medication, cyclosporin. This is our first inhibitor of cytokine production. It's extracted from a soil fungus. So let's talk about its mechanism of action. And the first one we need to talk about is the activation of the T lymphocyte. So when a T cell is activated, there's an increase in intracellular calcium. Now this activates a protein phosphatase called calcineurin. Now calcineurin dephosphorylates the transcription factor, nuclear factor of activated T cells. We refer to this as NFAT, so nuclear factor of activated T cells. Now NFAT moves to the nucleus of the T cell and increases the activity of genes coding for what? Interleukin 2 and other cytokines. So, and what did we talk about the interleukin 2? So it produces this activation of other cells and then starts the whole process of activating the immune system. So let's find out how cyclosporin inhibits all this. So cyclosporin binds to cyclophilin. Now this is a class of intracellular proteins called immunophilins. The cyclosporin and cyclophilin form a complex that inhibits calcineurin. Now calcineurin then cannot dephosphorylate NFAT, which we just talked about, and then NFAT cannot upregulate the production of IL-2 and other cytokines. So these drugs are also called calcineurin inhibitors. So let's do a recap. Cyclosporin binds to calcineurin. This forms a complex making calcineurin worthless. So that calcineurin can no longer activate NFAT. And remember, what did NFAT do? NFAT goes into the nucleus and then it upregulates the production of IL-2. So ultimately, cyclosporin is decreasing the production of IL-2. So interleukin 2 is not at high enough concentrations. It's not activating those T helper cells, which then increase the overall cytokine production. Let's talk a little bit about the pharmacokinetics. Cyclosporin can be given orally or IV, It's metabolized by cytochrome P450, so be aware of that, especially when you have other medications that either increase or decrease the metabolism of cytochrome P450. Excretion is through the bile. So for the therapeutic uses, so the most oftenly it's most effective in preventing acute rejection of transplanted organs, and that's our main lecture topic today. It's often combined in a double drug or a triple drug regimen with corticosteroids, which we'll talk about later, and antimetabolites, again, which we'll talk about here in a little bit. And then it can also be used as an alternative to methotrexate for the treatment of severe active rheumatoid arthritis or a severe unresponsive psoriasis. So these medications, again, can be used for multiple things. They're decreasing an immune response, therefore diseases such as rheumatoid arthritis or psoriasis, which are abnormal immune responses, can be effectively treated with these medications. Adverse effects, and there's quite a few of them. That's why these medications are problematic. First one you probably need to remember is nephrotoxicity. This is the most common adverse reaction. You have to monitor kidney function with cyclosporin. Very, very important. Hepatotoxicity is also very common. So what are we going to check? LFTs, or liver function tests. You can get hypertension, hyperglycemia, you can get altered mental status, gingival hyperplasia is very common as well. You can get, and this is very interesting and a good test question, increased incidence of lymphoma and other cancers. So you have a patient who's getting an organ transplantation, you put them on these medications chronically, and then they end up with cancer. Well, that's awful. So things like Kaposi sarcoma, skin cancers can be common, so be aware that you can increase the risk of cancer when you're doing organ transplantation. And then, of course, immunosuppression. So we're trying to immunosuppress people, so what happens when you decrease the immune system? Well, you make them more susceptible to infection. That's going to be common throughout all of these medications, and you need to be aware if you're treating patients who are on immunosuppressants that if they come in with any infectious disease, you got to take that really, really seriously because their body cannot fight off infection. So one notable infection you should probably know is CMV, or cytomegalovirus. You might get a question on this if someone comes in with a like a CMV retinitis. That could be very important to know if they're being immunosuppressed. CMV is a big player in viral infections. Next, we're moving on to another medication. This is tacrolimus. Some people will refer to this as tacrolimus, but it's actually pronounced tacrolimus. It's another medication. It's an immunosuppressant, but it's a macrolide antibiotic. Now, it's also, again, found in soil fungus. I guess we find a lot of immunosuppressants in soil fungus. Its mechanism of action is similar to cyclosporin, but there are some key differences. Now, cyclosporin binds to cyclophilin. Remember how we talked about that? Where tacrolimus binds to another immunophilin, FK binding protein, FKBP. Now, both mechanisms will inhibit calcinurins. Remember how we talked about how ultimately we were binding to calcinurin, which will form a complex, and then it'll inhibit NFAT and then decrease IL-2. So it's just a little bit different where we're binding to cyclophilin in regards to cyclosporin, and then we're binding to this FKBP in regards to tacrolimus. Therapeutic uses, similar to cyclosporin, so organ and stem cell transplantation. It can be given with corticosteroids and antimetabolites. It has benefit over cyclosporin is that when using tacrolimus, a lower dose of corticosteroid can be used. So you can decrease the adverse effects of corticosteroids. We'll go over those in a little bit as well because there's a lot of adverse effects to those. Tacrolimus can be used topically for moderate to severe atopic dermatitis, so very important to know that. Pretty commonly used nowadays as well. Pharmacokinetics can be given IV or orally for organ transplantation. We just talked about the topical use for atopic dermatitis. Tacrolimus is 10 to 100 times more potent than cyclosporin, so it is a stronger medication, so to speak. Metabolized by cytochrome P450, more specifically the CYP3A4, and then mostly excreted in the feces. Adverse effects, similar to cyclosporin. Nephrotoxicity, it's more severe than cyclosporin. Neurotoxicity, more severe than cyclosporin. Post-transplant insulin-dependent diabetes mellitus, but you don't get hirsutism, you don't get gingival hyperplasia as you do in the cyclosporin. And then you get a lower incidence of hypertension and hyperlipidemia than cyclosporin as well. So there's a bit of a trade-off here. You have to watch your nephro and your neurotoxicity a bit more with tacrolimus, but you don't get that hypertension, hyperlipidemia so much with the tacrolimus. Sirolimus is a similar medication, sometimes referred to as rapamycin, but now we call it sirolimus. It's another macrolide antibiotic, but it has a different mechanism of action than tacrolimus. Both sirolimus and tacrolimus bind to the FK binding protein, but sirolimus does not bind to calcineurin. Remember how cyclosporin and tacrolimus both are going to get after that calcineurin. Instead, it binds to what is called the molecular target of rapamycin. So this is kind of funny. I can imagine the scientists sitting around trying to come up for a name for this thing. What should we call a thing that rapamycin binds to? Well, they don't call it something cool like flaming laser death receptor or something neat. No, they say, well, let's just give up. Let's call it molecular target of rapamycin. Yeah, mTOR. So we'll refer to this as mTOR, and the name is what it is, molecular target of rapamycin. I wish the scientists would get a little more creative in their naming of things. I'd call things like Bobby or something cool, not just molecular target of rapamycin. So mTOR is involved in cell growth and proliferation, angiogenesis, and metabolism. So it is a very important molecule. Now, ultimately, without mTOR, you get inhibition of interleukin-driven T cell proliferation. Also, there may be some inhibition of B cell proliferation and immunoglobulin production. So let's talk about how this differs from the two medicines we've already talked about. So instead of blocking the production of interleukin-2, like tacrolimus and cyclosporin, remember that whole process was we're decreasing that IL-2 production. Sirolimus is blocking the effective IL-2 on cells. So IL-2 is still around, it's still probably at pretty decent levels, but the cells aren't responding to the IL-2. So that's the key difference that I try to remember between sirolimus and tacrolimus and cyclosporin. Decreasing IL-2 on one, decreasing the reaction to that IL-2 with sirolimus. Therapeutic uses. So, used for renal transplantation with cyclosporin and corticosteroids. The combination of cyclosporin and sirolimus is synergistic. So that's another good important point because sirolimus works later in the immune activation cascade. And that makes sense, what we just talked about, how it's decreasing the effectiveness of that IL-2 on the cells. So sirolimus is used in cardiology, which is another important point here. So sirolimus-coated stents that are inserted into the cardiac vasculature and can inhibit restenosis of the blood vessels by reducing the proliferation of the endothelial cells. So again, all these medications are used for transplantation, but they have these other secondary uses as well. Pharmacokinetics. Only taken orally, except for in the instance of those stents. Fatty meals can decrease absorption, so be aware of that. Has a very long half-life. Therefore, there's usually a loading dose that's used initially, and then you get titrated to your usual dose after that. Again, metabolized by cytochrome P450, more specifically the CYP3A4. Sirolimus will increase the serum concentration of cyclosporin. Therefore, when you're going to use these in combination, you have to be very, very careful, because what do you run into with cyclosporin? Remember, you're going to get your hepatotoxicity, you're going to get your nephrotoxicity. So you're going to have to decrease the dosages if you're going to combine these medications, and watch those kidneys, watch those livers. Adverse effects. Hyperlipidemia is a very frequent problem. Nephrotoxicity is more common when combined with cyclosporin. Remember, we just talked about that. Neurotoxicity, more common when combined with cyclosporin as well. Leukopenia, thrombocytopenia, nausea, and then, of course, things that have to do with immune system, impaired wound healing, and then more infections.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
He once amputated a man's leg with a spork and a packet of soy sauce. In addition to medicine, he is an expert in several disciplines, including marine biology, quantum physics, and Precambrian literary criticism, while his mustache holds fellowships at several prestigious institutions. He is the most exceptional doctor in the world.
Immunosuppressants. Immunosuppressants. Though I'm not sure any immunosuppressant could conquer my battle-honed army of natural killer cells. That reminds me of the time I switched my own kidneys to see if I could do it. Now, which cytokine is most important in activating antigen-primed helper T cells? Oh yes, that's interleukin-2. Study well, my friends.
Hi, I'm Dr. Mike McInnes, and we're going to go through the answers for quick review number 1 in your study guide. First question, besides sirolimus, what drug is used in drug-eluting vascular stents? So the other drug you can sometimes see in stents is paclitaxel. Paclitaxel is a chemotherapy drug that binds to tubulin and stabilizes microtubules so that cells can't undergo meiosis and cell division. Sirolimus, as we've just been discussing, attacks that mTOR, that molecular target of rapamycin that's involved in cell growth and proliferation. So binding that will block endothelial proliferation. That's proliferation of the neointima that covers the stent. We want to block that so the stent stays open and the coronary artery or whatever artery you've put it in stays patent. Next question. Which immunosuppressant can be used topically for atopic dermatitis? Well, again, this is tacrolimus. Tacrolimus, the brand name for this topical formulation of tacrolimus is Protopic. Atopic dermatitis is an inflammatory condition of the skin, sometimes called eczema. And so you have to have a functioning immune system to have inflammation. So if you can knock down the body's immune system, you can knock down the immune system's role in this disease. Next, what is a common shorthand abbreviation for tacrolimus? This is FK506. You'll see that written sometimes in notes or in charts, so be aware of that abbreviation. FK506 is the same thing as tacrolimus. Next, which cytokine inhibitor is known for commonly causing hyperlipidemia? Well, this is sirolimus. Next, in regards to adverse effects, what are some advantages of tacrolimus over cyclosporin? So tacrolimus will not cause hirsutism or gingival hyperplasia, and you get a lower incidence of hypertension and hyperlipidemia, which is a good thing. Next, cyclosporin can increase the risk of developing Kaposi's sarcoma. Describe the clinical appearance of Kaposi's sarcoma. Obviously, it does you no good to know that this drug is going to increase your risk of KS or Kaposi's sarcoma if you don't know how to recognize Kaposi's sarcoma when you see it. So, KS or Kaposi's sarcoma is a cutaneous malignancy that causes purple, polygonal, pruritic papules and plaques, which are raised palpable lesions. So that's all those P's, purple, polygonal, pruritic papules and plaques. These can arise on the legs, the back, the oral mucosa, the face, and the genitals. So you can think of penis as another P in that mnemonic. KS is associated with infection with human herpes virus 8, but it's now most commonly seen in patients who are HIV positive. So HIV causes immune suppression, obviously, so it's not unreasonable to remember that immunosuppressant drugs like cyclosporin could increase the risk of Kaposi's sarcoma. Next question. A 66-year-old man with end-stage renal disease, status post cadaveric renal transplant. He has hypertension and poorly controlled diabetes, and he presents with acutely rising BUN and creatinine. His immunosuppressive regimen includes cyclosporin and a low dose of prednisone. What would be your first step in determining whether cyclosporin toxicity is responsible for his new onset renal insufficiency? Well, this patient has several possible causes for renal damage. Maybe he has diabetic nephropathy. Maybe he has hypertensive renal disease. Those would be less likely to cause acute renal failure. They're more chronic kidney problems. Maybe he's rejecting his transplant. That can certainly happen sometimes, even with the best immunosuppressive regimens. The point I want to make here is that you can check a serum cyclosporin level and see if he's in the toxic range. Now, for most drugs, we don't have the luxury of checking a hydrochlorothiazide level or a metformin level, but with cyclosporin and some of these other immunosuppressants like tacrolimus, you can check the level and then adjust the dose as needed. That's the end of this quick review. Now let's go back to Dr. Lewis.
All right, so now we're switching gears to immunosuppressive antimetabolites. Now, these agents are generally used in combination with other medications like corticosteroids and the previously mentioned meds, cyclosporin and tacrolimus. The first one we're going to talk about is azathioprine. So this drug is converted to 6-mercaptopurine. Now, some of you might recognize this as an anti-cancer drug. So this is another situation where we have an immunosuppressive drug, but it can also be used outside of the organ transplantation use and be used for an anti-cancer drug. So the mechanism of action, so think of it this way. So when there's an immune response, there's a rapid proliferation of immune cells. Your body recognizes an infection, so it upregulates very quickly to increase the proliferation of all these cells to fight off that infection. Now think of this as being sort of similar to many cancer situations where you have unchecked, abnormal, rapid tumor growth. So azathioprine is a purine analog, and the rapid proliferation of lymphocytes is inhibited because of the decreased availability of purine. So it works in the same situation as cancer. We take away the nucleoside transcriptors there, and you can't reproduce those cells. So because there's just rapid proliferation, they're the only cells that seem to be affected. All right, so for therapeutic uses, we use this for renal transplantation, acute glomerulonephritis, systemic lupus erythematosus, especially when it's involved with the kidney, rheumatoid arthritis, Crohn's disease, multiple sclerosis, so there's lots of uses for this thing. Adverse effects, bone marrow suppression. So think of this again, similar to a cancer drug, so it's decreasing our bone marrow production. If it's combined with ACE inhibitors or TMP SMX, also known as Bactrim, in a renal transplant patient, this can lead to more leukopenia. Azathioprine is metabolized by xanthine oxidase, so this is a good test question. So allopurinol is a xanthine oxidase inhibitor. And what do we use allopurinol for? Well, we use it for gout. So if you have someone with gout who's taking allopurinol, you have to be very careful using something like azathioprine or 6-mercaptopurine because this will increase the serum levels of azathioprine and the dose must be adjusted. So it can be dramatic. So you really have to think about how you're going to start these medications. If they're taking allopurinol, if they have severe gout, you have to be very careful because you're going to get very high dosages of that azathioprine. All right, so we're going to change gears again. We're talking about mycophenolate mofetil. So this medication has replaced azathioprine, so we're not using azathioprine quite as often for these situations. In most cases because of better safety and improved graft survival. So this is another anti-metabolite. Mechanism of action. So it's hydrolyzed to mycophenolic acid, also known as MPA, in the GI tract. Now, this will inhibit inosine monophosphate dehydrogenase. Now, this ultimately will result in an inhibition of the formation of guanosine phosphate. So, therefore, it's similar to azathioprine and 6-mercaptopurine in that it works on rapidly proliferating cells that require purine production. So, again, think of our cancer situation, rapidly producing cells, similarly to a rapid increase in lymphocyte production. Therapeutic uses. Organ transplantation. It's used in combo with corticosteroids and cyclosporin. Lupus nephritis, rheumatoid arthritis, inflammatory bowel disease. Pharmacokinetics, it's orally administered. You don't want to take this with antacids containing magnesium or aluminum or cholestyramine because this will decrease the absorption of the drug overall. It is highly bound to albumin, so if you have states where either low albumin or other medications that might bind to albumin, you have to be careful with both medications, though it doesn't seem like this medication gets bumped off of albumin, but if you have another medication, like say warfarin, it might bump other medications off of albumin. Excreted in the urine. Now, there's also an enteric-coated version of the drug that helps to minimize the GI side effects. So let's talk a little bit about the adverse effects. So nausea, vomiting, diarrhea. So those are the big ones, very common. But you can also get some headache, some hypertension, and some reversible myelosuppression. Remember, myelosuppression or bone marrow suppression, very common with these anti-metabolites. Next, let's move over to classification of medications, the antibodies. So antibodies have now been developed in order to help in organ transplantation. One technique to produce these antibodies is to immunize rabbits or horses with human lymphoid cells, which then produces a mixture of polyclonal antibodies directed against a number of lymphocyte antigens. Another technique is to produce hybridomas. Now, these are produced by fusing mouse antibody-producing cells with malignant plasma cells. Now, these hybrid cells can then produce a specific antibody directed against a more specific target. Now, let's take this another step. Recombinant DNA technology has now been able to replace part of the mouse gene sequence with human genetic material, making the antibodies what we call humanized. Now, this is helpful because it makes the antibodies less antigenic and you get fewer allergic reactions. So let's recap real quickly. So in the first one, we're immunizing rabbits and horses. So we're just putting some human lymphoid cells in there, and then they're producing this big kind of mishmash, a mixture of polyclonal antibodies. And then we take those antibodies, and then we hope that those will go against some of our lymphocyte antigens and kill off those lymphocytes to cause that immunosuppression. The second one is that we're combining mouse antibody-producing cells with some plasma cells, and they produce a very specific antibody. And then we can further, through kind of reverse transcriptase and recombinant DNA, we can go back and kind of remove that mouse DNA to make it more humanized. So we're producing these antibodies, and we're hoping that they're more specific just for certain lymphocytes in order to decrease the overtoxicity of our medications. In order to better understand the naming of these drugs, you should be aware of a couple of things. So muro, M-U-R-O, means that they are from murine or mouse sources. XI means, if it's in the name of the drug, it means that the agent is a chimeric antibody. And then ZU means that the agent is humanized. We just talked about how that recombinant DNA technology can remove the mouse DNA, and then you're going to get this ZU part of the name. We'll go over this in a second when we actually have some actual names to talk about. So the first section we're going to talk about are the anti-thymocyte globulins. So first, what is a thymocyte? Well, they're the cells that develop into T cells in the thymus. So they're immature T cells, so to speak. Now these anti-thymocyte antibodies are produced by immunizing rabbits or horses with human lymphoid cells. So that's the first technique that we talked about. Now the antibodies bind to the surface of circulating T lymphocytes and cause some form of cell death. So those antibodies are directed towards your own lymphocytes. Therapeutically, they're used at the time of transplantation to prevent an early rejection or to treat severe rejection episodes. So this isn't given as a long-term chronic medication. They're used right in the beginning so your body doesn't immediately reject the organ, or if you're seeing signs of severe rejection, then you can put this in as a savior as well to help decrease the reaction. Now, they're given IV, and their half-life is 3 to 9 days. The adverse effects include chills, fever, leukopenia, and thrombocytopenia. First, we're going to talk about muromonab. As you can tell from the muro part that we talked about before, this is a murine mouse monoclonal antibody, and this is produced by the hybridoma technique that we discussed earlier. Mechanism of action. So this antibody is directed against glycoprotein CD3 antigen. So muromonab is a CD3 antigen antibody. This is located on human T cells and is very important in the recognition of antigens. Circulating T cells are depleted after giving this medication and the immune function is decreased. T cells will return to normal within 48 hours of discontinuation of therapy, so very short acting. Pharmacokinetics, given IV, there can be a transient increase in cytokine release after administration. So this initial cytokine release can be very dramatic. So sometimes we pre-medicate the patient with methylprednisolone, diphenhydramine, and acetaminophen. Adverse reactions, anaphylaxis reactions. Remember, this has mouse origins in it, so you're going to get more allergic reactions. Fever is pretty common. CNS effects, so seizures, encephalopathy, cerebral edema, aseptic meningitis, headache, opportunistic infections. And what's our virus that we worry about as an opportunistic infection? CMV or cytomegalovirus. Contraindicated in patients with a history of seizures, pregnancy, uncompensated heart failure, and breastfeeding. And overall, muromonab is very rarely used today because of its side effects. So still good to know what it is, but it's not used near as often. Let's talk about some IL-2 or interleukin-2 receptor antagonists. So basiliximab and daclizumab. So you'll notice with the basiliximab, it has that XI in it, and you'll know with daclizumab, you'll see a ZU. So remember our rules before. So these medications are again produced by the hybrid technique with mice. However, through genetic engineering, the murine component has been removed by a percentage. So basiliximab is chimerized with 25% murine and 75% human protein. And daclizumab is only 10% murine and is categorized as humanized. So you'll notice the ZU and the XI differences there. Mechanism of action. So both are anti-CD25 antibodies. So that's the important part here, CD25 antibodies. They bind to the alpha chain of the IL-2 receptor on activated T cells. So overall, this will inhibit proliferation of the T cells. Basiliximab is 10 times more potent than daclizumab. Pharmacokinetics, they're given IV. Daclizumab, serum half-life is about 20 days, but the blockade of the receptor is 120 days. So usually 5 doses are given. First is given within about 24 hours before transplantation, then given at 14-day intervals after that. Basiliximab is only given twice, 2 hours before transplantation, and then in about 4 days. Adverse effects, these are really well-tolerated medications, but they do have some GI side effects, so be aware of that. Alemtuzumab is our next medication. Humanized monoclonal antibody directed against CD52. So remember, CD52 and alemtuzumab. This will deplete T cells, sort of similarly to our previous mechanisms. It is long-lasting, so its effects are good up to 1 year, so very long-lasting. Uses transplantation, refractory B-cell chronic lymphocytic leukemia. Adverse effects, there's this first dose cytokine release syndrome, remember how we talked about before, so you can pre-medicate with steroids, diphenhydramine, and acetaminophen. You can get some neutropenia, you can get anemia, and rare pancytopenia. All right, now finally we're going to talk about corticosteroids. Now we cover corticosteroids in several of our lectures, including adrenal hormone lecture, the anti-inflammatory lecture. We're not going to go into great detail here with that, but we will give you the basics. In regards to immunosuppression, the corticosteroids were the first agents used in transplantation and in various autoimmune disorders. Prednisone and methylprednisolone are the most commonly used for transplantation. It is important to note that they are always used in combination with other drugs, like the ones we've talked about so far today. They're not going to be given alone. They have too many side effects to use alone at high dosages. For their mechanism of action, we're not 100% sure why these things work. Now, they are able to rapidly reduce lymphocyte populations by lysis or by redistribution. We're not really sure which one is more prominent. They bind to the glucocorticoid receptor, which then regulates the translation of DNA, thus affecting things like the inflammatory response. They're used for a lot of things other than transplantation. We use this for inflammatory disorders, rheumatoid arthritis, psoriasis, for poison ivy. I mean, you'll use them for back pain occasionally, all sorts of things. So they can be used in lots and lots of different things. Adverse effects, and this is the big problem with steroids, they can give you diabetes, they can give you elevated lipids, hyperlipidemia, cataracts, osteoporosis, adrenal suppression. So if you use these medications long enough, they're going to give you a lot of problems, and therefore we like to use the lowest amount possible. And that goes back to the whole point of our immunosuppressants. We're going to use 2 or 3 meds at a time. We're going to treat it at different mechanisms of action. We're going to try to use the lowest effective dose. Now, ultimately, we have to save the organ that we're treating, but we don't want to use toxicities of these other medications to cause other problems. So that's why we don't use our steroids all by themselves, and that's why we combine them with other medications, so then we can decrease that steroid dose, decrease the dosages of the other medications, and make people healthier overall.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Thank you. Now, here's a little obscure Irish tune called The Ballad of Mike O'Fenelate. What malignancy is associated with mycophenolate mofetil lymphoma? Oh, lymphoma. Mycophenolate increases the risk of lymphoma. And why is mycophenolate mofetil not used in pregnancy? congenital malformations of the ear and face. And first trimester miscarriage, mycophenolate morphetilis teratogen. Hey, where are you going? Come back. Oh, I can do requests. Man, I knew I should have played Stairway.
All right, let's go through the answers for quick review number 2 in your study guide. First question, for what indications is alemtuzumab FDA approved? So it's approved for use in B-cell chronic lymphocytic leukemia, or CLL. Now, it's sometimes used off-label for the treatment of T-cell lymphomas, and here we're talking about using it off-label for immunosuppression with bone marrow transplants and kidney transplants and that kind of thing. Next, a patient is started on alemtuzumab, then develops fevers, rigors, and hypotension. Now, that word rigors you'll hear pronounced rigors by some physicians. I'm not really sure why. We never talk about rigor mortis, being the stiffness a body gets after death. We talk about rigor mortis. Well, this is the same thing. It's rigors. So anyway, what has caused this reaction of fever, rigors, and hypotension, and what could have been done to prevent it? So this is a description of cytokine release syndrome. With the first dose of alemtuzumab, the antibodies bind to the T-cell receptors and activate the T-cells, and this causes release of the stored cytokines. And this produces a type of systemic inflammatory response similar to what we see in severe infections and shock. So you can prevent this by pre-medicating with steroids and diphenhydramine, which is Benadryl, and acetaminophen, which is Tylenol. Next, which 2 medications are known for causing cytokine release syndrome? So we already mentioned one of them, and that's alemtuzumab. The other one is maromanab. Next, how is immunosuppression with azathioprine similar to treatment of cancer with anti-cancer drugs? Well, in both cases, we're inhibiting the proliferation of rapidly dividing cells. Next, which enzyme metabolizes azathioprine? Well, this is xanthine oxidase. And what medication will increase the serum concentration of azathioprine? Well, it's allopurinol, which we normally use in the treatment of gout. It's a xanthine oxidase inhibitor. So if you inhibit xanthine oxidase, you're inhibiting the metabolism of azathioprine, and then your azathioprine levels will rise. Next question. Which immunosuppressant is poorly absorbed when taken with antacids or cholestyramine? Well, this is mycophenolate mofetil. Next, classify basiliximab and daclizumab as being chimeric or humanized. Remember, there's this nice mnemonic. They actually work in these letters into the name so you can kind of remember what it is. Basiliximab is chimeric. You've got that XI or that chi in there for chimeric antibodies. And then daclizumab is humanized because you've got the ZU. Next, which antibody is now rarely used because of its severe adverse effects? Well, this is maromanab. The adverse effects of maromanab include fever, seizures, headache, encephalopathy. It really causes a lot of bad stuff. It also can cause cytokine release syndrome, and it will also increase your risk of CMV infection. All right, that's the end of this quick review. Now it's time for the end of session quiz. I want you to pause the video, complete the end of session quiz in your study guide, then restart the video, and we'll go through those answers together. All right, let's go through the answers to the end of session quiz together. First question, match the drug with its mechanism of action. So the first drug is cyclosporin. Remember, this is a calcineurin inhibitor. It inhibits calcineurin. Next, sirolimus binds the molecular target of rapamycin, the mTOR. Next is maromanab. This is an anti-CD3 antibody. Mycophenolate mofetil inhibits formation of guanosine phosphate. Basiliximab is an anti-CD25 antibody. And alemtuzumab is an anti-CD52 antibody. Next, a 55-year-old patient has been on chronic immunosuppression for a liver transplant performed 3 years ago. He's now experiencing polyuria and polydipsia. What's the probable cause of these symptoms? Well, this patient has probably been taking corticosteroids chronically as part of his anti-rejection regimen, and this can lead to the development of diabetes mellitus. Chronic glucocorticoids, chronic steroids can cause lots and lots of different adverse effects, including hyperlipidemia, cataracts, osteoporosis, adrenal suppression, and raise the blood sugar or cause diabetes. Next, match the drug with its adverse effect. So we have prednisone, which can cause osteoporosis. That's one of those glucocorticoids that we just mentioned, so that can cause osteoporosis. Basiliximab can cause GI side effects. Cyclosporin can cause gingival hyperplasia. Muromonab can cause seizures, cerebral edema, encephalopathy. We mentioned that briefly. And then sirolimus can cause nephrotoxicity that's worse when combined with cyclosporin. Next, the antithymocyte globulins are used most often in what clinical scenario? So these are used at the time of transplantation to prevent early rejection or to treat severe rejection episodes. Next, what two medications, if given with azathioprine, can lead to more leukopenia? So if you give trimethoprim sulfamethoxazole, or the brand name is Bactrim, with azathioprine, that can increase your risk of leukopenia. And you can also see this with ACE inhibitors given concomitantly with azathioprine. Next, cyclosporin, tacrolimus, and sirolimus work to either inhibit the production of or the effectiveness of what cytokine? Remember, this is a very important cytokine in stimulating T cells. This is interleukin-2. Next, what are the primary actions of interleukin-2? So interleukin-2 stimulates the proliferation of antigen-primed helper T cells. These cells then produce more interleukin-2, and they also produce interferon gamma and TNF-B, or tumor necrosis factor B. And these cytokines then activate natural killer cells and macrophages and cytotoxic T lymphocytes. So you've got to have interleukin-2 at the beginning to kind of trigger this whole immune response. Next, define the following descriptors for the immunosuppressant antibodies. So again, this is a nice little thing. It's really easy to remember this. Muro means it comes from a murine or mouse source. Chi, XI, means that the agent is a chimeric antibody. And ZU, or ZU, indicates that the agent is a humanized antibody. Next, muromonab is contraindicated in which patients? So we talked about the seizures and encephalopathy. So muromonab is contraindicated in a patient with a history of seizures. It's also contraindicated in patients who are pregnant, who are breastfeeding, or who have uncompensated heart failure. The last question, how can you prevent the transient increase in cytokine release after administration of muromonab or alemtuzumab? So this is that cytokine release syndrome. And we said we're going to prevent this by pre-medicating with methylprednisolone or other corticosteroids, and also diphenhydramine and acetaminophen. So that's the end of the end of session quiz, and that's the end of this lecture on immunosuppressant drugs. Good luck studying.